Hey, it's Dr. Shelley, and you are scheduled for a DaVinci hysterectomy with or without removal of your ovaries. And that is why we are having a conversation. So, this is your pre op discussion on what to expect during the surgery and what the risk and benefits are. So, obviously, we've already discussed other treatment choices, and you have chosen to proceed with a hysterectomy. Yay! That can be a wonderful decision. And I always tell people it's all about the mental. If you go in with the idea that this is going to be great, no more bleeding, no more periods, no more cramping, able to have sex whenever I want to, then this can be a great thing, right? The risk of any surgery, including this one, include the risk of infection. Um, we give you an antibiotic through your IV, right in the pre-op area. So this is not an antibiotic that you need a prescription for ahead of time. Bleeding. That's, we always have blood available. The great thing about the Da Vinci procedure is that it is 3D, and I can bring your uterus up to my face. I tell people I can't put my head in your pelvis, but I can bring your uterus up with the Da Vinci robot, and so it's actually less bleeding. Also, the instruments torque 360 degrees. I can't do my hand that far, so it's very easy to control bleeding in that setting. So we actually have significantly less bleeding than with an open case and or with traditional laparoscopy, where it's more like a joystick where you go left when you want to go right, and the instruments don't just go like side to side. So, but with any major surgery, we have blood available, and so we do have you sign a blood transfusion consent form. If you do not sign the blood transfusion consent form, what you are saying is that you would rather bleed to death and die than to receive a blood transfusion. So do take that very seriously. If you are abstaining for a blood transfusion due to religious reasons, there are forms for that, and your surgery needs to be done at Advent Health facilities. South Lake and Orlando Regional will not do your surgery if you refuse blood transfusion. And that's just for your safety and theirs, because they want to, have that available if needed, period. Now, the great thing is that, like I said, there's very little blood loss with a Da Vinci case, unless something went very, very wrong. And so the likelihood of you waking up and having blood hanging after a procedure is extremely low, unless you walk into the surgery extremely anemic. And if you did, we've already had that conversation, and we probably have already made arrangements for us to start giving you blood even during the procedure, even before it starts. So if not, it's very rare, but there is a consent form, and that's why you're signing it. I do not give out blood cavalierly, so if you wake up and there's blood hanging after your surgery is performed, then it was a life or death situation and you really needed it. Otherwise, like I said, especially if you're young and healthy, I will let you recover from the surgery. And if every time you get up, the world's going around and around, then I'm going to recommend with you that we consider a blood transfusion. But if you're able to handle it, then wait and see how you do with it. So that's all for the actual blood transfusion that you need to know, but that's what the consent form, like I said, is for. With any surgery, there's a risk of damage to adjacent organs. Of course, your bladder is there, your bowels are there, your blood vessels are there. If we're not planning to remove your ovaries are there. And so it, the key thing I tell people is that injuries can occur. It's not that we can avoid all injuries, but the most important thing, A, we try to avoid it, but B, try to know that it occurred. So, what we do to help prevent injuries is we actually do have you do a bowel prep the day before. You will not like me very much for that, but think of it as your yearly colonic cleanse, and it's not a bad thing. The bowel prep. Will start usually in the afternoon. I usually tell you that you eat a regular breakfast and lunch, because you're going to otherwise be very, very hungry by the next day. But don't shovel in everything, piece of food that you possibly can find, because guess what? Everything you put in is coming back out again. And we usually have you start the clear liquids and the bowel prep at about 3 p.m. If you are working, I would recommend that you wait till you're off work, because it does start to kick in and work pretty quickly. And then, yes, if you wait too late, you will be up all night pooping. But don't worry about that, because anesthesia is one of the best sleeps you'll ever get. So as long as you can crawl out of the bed and get to the hospital, you will actually sleep quite soundly and catch up on any sleep that you were missing during the surgery and afterwards. But the bowel prep, that's why we have it there, is so that if for any reason there was injury to your bowel, I can call in the general surgeon and we can repair it. If there's injury to your bowel and it is full of stool, then you end up with what we call a colostomy, which is where we reroute your bowel out of your belly temporarily until it can heal, and then you have to go back, have another surgery, and have it put back in. So let's just do the bowel prep, and we don't have to worry about those little tidbit things now, do we? So that takes care of that. As far as the bladder, you will see on your consent form that there is another procedure added besides the hysterectomy removal or not removal of the ovaries. There's a something called a cystoscopy that's listed. The cystoscopy is where I go in after we've completed the hysterectomy into your bladder. You're still asleep, and I look around to see, is there any injury that can be detected to the bladder, and also, are the ureters working correctly? The ureters are those thin pipes that connect from the kidney to the bladder. And so there is a risk when I am dissecting onto your side walls, removing your ovaries and your fallopian tubes, that there could be a risk to the ureters. Also, when we get down low on the cervix, down to the neck of the cervix where the cervix inserts, excuse me, to the uterus where the cervix inserts, the ureter is very close to where the blood vessels are. So there's another risk for injury there. So what we do after the case is go back and look at the ureters. And if the ureters are spewing out urine, then that usually means that they're very healthy. And so it's not 100%, but it's pretty darn good. If there's injury to the ureter, it'll shut down. If there's complete injury to the ureter, then of course the urine can't get out. So that's why the cystoscopy is performed. And it's a very simple procedure. You won't notice any difference. If you're being sent home that day, just know that your urine, we do give you a medication so that we can see the urine, because otherwise it can be very pale. And that medicine can make your urine look a different color. So that's what that's all about. It's not that there's something weird and funky going on with you. Um, the um, uh, and the cystoscopy really doesn't hurt or cause any more discomfort than just having had the catheter in your bladder, which is of course present throughout the case. And if you're going home, the catheter goes home. No, the catheter comes out before you even leave the operating room. If you're any reason are staying in the hospital, then and we know that ahead of time, then the catheter would stay in. Now, that is a reason why you may not be able to go home, is if you were not able to void, then obviously that would be a reason that we would have to potentially keep you. Or actually, more likely, we would put a catheter in and you would go home with that. But we don't think about those kind of things. So that's extremely, extremely rare. Knock on wood, I don't think I've done that in years. So anywho, what else do we have? So we got that, we got that, we got that. Obviously, with any surgery, there's a risk of damage to your blood vessels. Like I said, if we're leaving your ovaries, then while we're dissecting out everything else, there could be an injury to the ovary. And so if so, that would be repaired. If it was not able to, for some reason, bleeding was not able to be controlled or something like that, it could potentially be removed, but that's pretty rare. The and so if we're doing surgery, and this goes for any laparoscopic surgery, not just the DaVinci cases, if there's ever a concern and thought that I cannot get things taken care of through the scope, then there's always a possibility of switching to what we call an open laparotomy, where we actually make an incision and go in. And so that's always a possibility. We let you know that, but that's, once again, is extremely rare. Normally, unless we've already had that conversation and your fibroids are extremely large or the mass is extremely large and there would be difficulty with getting it taken care of through the scope, then usually we are able to do things through the DaVinci and you don't have to have an open laparotomy. But after all, it's about your safety and it's about getting the surgery done. So you would rather wake up and have a small scar on your belly and have your hysterectomy performed than me wake you up and say, well, we had to stop because we couldn't finish doing it through the scope and we didn't want to open you. So anyway, food for thought. And so with any surgery, there's a risk of blood clots in your legs. We put massagey things on your legs to decrease that risk. And also we'll give you, if you end up staying in the hospital, medication to help decrease blood clots as well. If you're going home, you're moving and grooving a lot, so we don't really worry about that. And you don't have to, there's nothing that you're going to need a prescription for. These are all things that are done for you in the hospital. If you had a deep venous thrombosis or a DVT, or a blood clot is another word for it, in your leg, and it broke off and went to your lungs, then that's a pulmonary embolism. That is a very dangerous dangerous thing. We do not want that to happen to you. It can cause severe shortness of breath, chest pain, and of course, it could lead to death if the blood vessels block the airway to the point where you're not able to get oxygen to your lungs. So that's a bad thing. We don't want that to occur, and that can occur from the blood clot. Also, we fill your belly with air so that we can see. Otherwise, everything would be a pancake. We wouldn't be able to make heads or tails of anything. So, if for any reason that air ended up into your blood vessels and ended up in your lungs, that would once again be a bad thing. Um, and with any surgery, uh, there's a risk of death. You know, we do not expect anything bad to happen to you. I have to tell you that that's a possibility. And if you've heard this spiel before, you know that I tell people you take your life in your hands every time you get behind the wheel of a car, but we do it every single day. So, same thing here. We don't expect anything bad, but we just have to tell you that that's a possibility. I don't believe that God takes you before it's your time, and I would hope to God that it's not during this surgery. So I'm not here to scare you, but we have to tell you all of the risks that go with surgery. And this would be the same if I was doing your appendix or anything else. There's really nothing specifically unique to the hysterectomy besides um, like if we're near the ovaries or something like that, and we were trying to leave your ovaries. If you're taking your ovaries, then realize that that will lead to premature menopause or what we call surgical menopause if you have not already gone through menopause on your own. If you're already menopausal, you shouldn't really notice much of a difference unless you're just freshly menopausal, because those ovaries have been conked down for a while. If you're in the perimenopause age group or younger, then you will notice when your ovaries are removed because that's what gives you those hormones. So you will be on hormonal therapy, or as I tell people, you will not like yourself, and pretty much nobody else is going to like you either. So if you're going into this surgery thinking that you're going to get everything out and you're not going to be on hormones, I would reconsider that. We probably need to have some more discussion. If we leave your ovaries, then you should walk out the way you walked in, meaning if you're already having hot flashes, night sweats, and mood swings, then you're going to have even more when you wake up because one of the main blood supplies to the ovaries is the uterus. So when we take it away, you could certainly notice worsening of symptoms that you already had. However, if you're walking into the surgery and you don't even know how to spell hot flash or night sweat, you've been doing great, then you should be fine on the other end. If you did for any reason wake up and you were noticing some hot flashes or night sweats, or you noticed that your moods were all over the place, that's usually a very temporary thing. The ovaries have what we call collateral blood supply that comes from the side walls, and so even though they're missing their main blood supply, if we give them a couple of months, they usually will come back to themselves. And so we will put you on some hormones just temporarily, and usually you're able to stop those. Um, um, as always, your health is my primary concern. So if we are planning to leave your ovaries, but I go in there and those ovaries look abnormal, unless you've specifically told me not to take them, then I will take the one that appears to be abnormal, and or both if that was the case, versus waking you up, leaving them in, and having to risk doing another surgery later. If that is something that you do not want to have done, then once again, we should have already had that conversation, and if not, we need to have it. So I think that goes over all of the risks that go with the surgery. As far as what to expect on the day of surgery, first of all, like I said, we will be doing the bowel prep the night before, the afternoon or evening before. If your surgery is in the morning, you will have nothing. You will be on clear liquids once you start your bowel prep, and so that means you can see through them. Orange juice is not clear. Water is clear. Grape juice is clear. Apple juice is clear. Chicken broth is clear. So those are the kind of things that you want to be drinking. And you do want to drink a lot of those. And so don't be thinking that you can't have it. You can drink as much water and clear liquids as you want between the time we start the bowel prep and midnight. If your surgery is first thing in the morning, you cut off all fluids after midnight, except for taking your blood pressure medicine with a sip of water on the day of surgery. If your surgery is in the afternoon, you dial back 8 hours, and it is 8 hours hard stop. So that means if your surgery is at 12, you can back it up. And if you happen to wake up in the morning at 4 a.m. to 2 or 3 a.m. and you wanted something to drink, you could have it. But if you drink something within the window that you're not supposed to, they will cancel your surgery. And that is for your safety because you could actually bring up whatever content is in your stomach and it could go down into your lung pathway, and that can kill you. So, or land you in the hospital in the ICU extremely ill. So there's a reason why things are told for you to do. So you need to not, this isn't the time to kind of doubt whether or not the recommendation should be adhered to. So, um, fluids, like I said, till midnight if your surgery's first thing in the morning, or 8 hours before the surgery, hard stop. And you can certainly do it sooner than that, but not too much sooner than that. And if your surgery's in the afternoon, um, the the hospital will contact you and tell you when your pre-op is at the hospital. And at the hospital, when you go for your pre-op, they will basically say, "This is what you're having done. Are you aware?" And some of them will do it by Zoom, and some of them won't. Well, by telehealth, and some of them won't. And they get the blood to have blood available, and they go over your consent forms and make sure you're comfortable with that. If they don't, then all of that will be done the day of surgery. It just means usually that they make you come in even more ungodly earlier than you need to. Usually that you are there, like if your case is at 7:30, you are there at the hospital by 6 a.m., just so we're clear. But the hospital is who tells you when your case goes and what time. And that's usually they call you the day before. So you may have a set time that my surgery scheduler has given you, but that may change based on what happens in the hospital. So do make sure you are communicating with them as well. If you do not already have a pre-op appointment, that you check with my surgery scheduler to find out what's going on with that. Um, the day of surgery, you can bring one person. Do not bring a whole bunch of people, because they're not going to be allowed to be there. And I will see you before the surgery starts. I will also talk to whoever is with you before the surgery starts, and I will talk to them after the surgery. I will talk to you as well. You will not remember that I talked to you, but I will. So I think that takes care of everything I can possibly think of that goes along with the surgery. If you have any other further questions after you watch this video and you've done your consent forms, then please discuss them with my surgery scheduler. And then if you still need to discuss anything further with me, let them know and we will get that taken care of as well before the surgery. The morning of surgery is not the time to pull out a list and go, "Hey, Dr. Glover, I had a couple more questions that I wanted to have." That's time to get your surgery done. So I hope you guys are good with that. If there's any other questions, like I said, let my surgery scheduler know, and I will see you the day of surgery. Take care.